Welcome to this Managing Malnutrition in Care Homes training created by the NHS Kerno Clinical Commissioning Group Care Home Support Dietitians. This training has been delivered in many care homes across Cornwall and teaches staff how to identify and manage malnutrition risk, including how to use our Managing Malnutrition in Care Homes resource pack. You should have already received a PDF copy of this and have hopefully all had a chance to look at it. The food-first approach to managing malnutrition may not be appropriate for residents who have complex nutritional needs, for example, severe renal disease or complex gastrointestinal disease. If you have residents with complex nutritional needs who are at risk of malnutrition, please discuss your concerns with their dietitian. If the resident is not currently under the care of a dietitian, please ask their GP to refer them to the dietitian for individual assessment. This training video can be used for individual or group training and is appropriate for new or existing staff as induction or mandatory training. This video is for staff who undertake must screening and nutritional care planning. There are separate videos for care or catering staff who do not undertake care planning or nutritional screening.
The Care Home Support Dietitians aim to ensure that care homes are confident in managing malnutrition. Alongside this training, we are undertaking ongoing audit of how malnutrition is managed in your care home. We'd also like to know how useful you find the training, so please complete the online questionnaire and feedback form after completing the training. Your manager can provide you with the link. Once you have done this, your manager will request your certificate of completion.
Providing good nutritional care to your residents is essential. There are many guidelines and publications that focus on nutrition in care homes, and it is useful to have an awareness of them. I'm sure you will be aware that the Care Quality Commission is the regulatory body for care homes. One of their fundamental standards is food and drink. It states that residents must have enough to eat and drink to be kept in good health. There is also Regulation 14 from the Health and Social Care Act, which describes how care homes must ensure their residents have adequate nutrition and hydration to sustain life and good health and reduce the risk of malnutrition and dehydration whilst receiving the support they need. There is also the NICE quality standard, Nutrition Support in Adults, which requires all care homes to take responsibility for identifying residents who may be at risk of malnutrition and provide nutrition support to everyone who needs it. There are many more publications besides these, and we wanted to highlight the emphasis that is put on nutrition and the requirement that homes have to provide good nutritional care. Ultimately, you are responsible for the nutritional well-being of your residents.
We are also continually monitoring the use of oral nutritional supplements and working with GPs to ensure they are prescribed appropriately. Sometimes supplements are started in hospital and continue when a resident is discharged, although these may no longer be needed. We also frequently see supplements prescribed where residents could otherwise be treated with a food-first approach, as discussed in today's training. If any of your residents are taking oral nutritional supplements, GP practices may be reviewing these prescriptions and stopping any that are inappropriately prescribed and will send a letter to notify you. If you think oral nutritional supplements have been stopped inappropriately and that using our resources to treat that resident is not sufficient on its own, you'll need to contact the GP surgery to consider whether they can be re-prescribed.
Within this training video, we will cover what malnutrition is, how to identify malnutrition risk using the Malnutrition Universal Screening Tool, nutritional care planning, and treating malnutrition risk.
So what is malnutrition? Malnutrition very simply means poor nutrition and can refer to both under or over nutrition. We will discuss just undernutrition in this training. Malnutrition can occur when there is a deficiency of energy, protein, or other nutrients which can cause adverse effects. By energy, we mean the calories we get from our food and drink. Protein we get from mainly meat, fish, dairy, beans, and pulses. And other nutrients means mainly vitamins and minerals. 35% of care home residents are likely to be at risk of malnutrition. Take a moment to think about how many people that might be in your own home. It is important to recognise that malnutrition is generally a treatable condition. By identifying and treating it early, we can help to prevent long-term complications.
So why does malnutrition occur? Identifying why malnutrition occurs is the first step in guiding what action needs to be taken. Have a think about why you think some of your residents might be at risk of malnutrition or have become malnourished. There are many factors that may cause malnutrition, including poor appetite, nausea or vomiting, constipation, a sore or dry mouth, mouth ulcers, poorly fitting dentures, low mood, pain, side effects of medication, a poor swallow or poor coordination, dementia and poor mental health, poor absorption may be due to certain medical conditions or illness such as COPD or infection. All of these factors here can quickly lead to insufficient nutritional intake, unplanned weight loss and malnutrition. When we train in care homes, we always highlight that it is vital to identify the underlying cause of malnutrition, as if they are not addressed, there may be limited success in actually reducing risk of malnutrition. To help you identify possible causes of malnutrition, there is a table within the resource pack which lists possible causes with suggested courses of action to take. For example, if you have a resident who has poorly fitting dentures, this may be impacting on their ability to eat sufficient nutrition, and you may need to consider making a dental referral.
We know that the consequences of malnutrition can have a big impact on quality of life. Every part of the body needs nutrients to survive and thrive, and so having insufficient nutrition potentially affects every system in the body. It can lead to increased risk of infection, delayed recovery times and pressure ulcers. Inadequate intake will also result in the body drawing protein from the muscles to be used as energy. This can then cause reduced muscle strength and increased risk of falls. Malnutrition can also cause low mood, which in turn can affect how much someone wants to eat. All of these consequences can lead to reduced independence and increased care needs, with potentially more GP visits and hospital admissions, all of which place additional costs and pressures on the health and social care system.
So let's discuss next how we can identify malnutrition risk. In care homes, it's recommended that the Malnutrition Universal Screening Tool, or MUS for short, is used to screen for malnutrition risk. This should be used on admission and monthly thereafter for every resident where possible, not just those who are visually underweight or have lost weight. The full tool can be found online, but there's also a version in our resource pack. A lot of electronic care records within care homes are set up to calculate the MUS score for you, so you don't necessarily need a copy of the tool. However, it's vital that this is set up properly, as the MUS score may not be calculated correctly otherwise. If you're in doubt following this training, please contact your care record provider. A useful way of checking MUS scores is also to use the online MUS calculator. This is easily found online on the BAPEN website.
So let's discuss calculating MUS scores manually. It is important to have a good understanding of how this is done. Step 1 involves calculating body mass index, or BMI, and assigning a score. So for a BMI of over 20, a score of 0 is given. For a BMI of between 18.5 and 20, a score of 1 is given. And where BMI is less than 18.5, a score of 2 is given. You can calculate BMI using an online BMI calculator or the BMI chart within the MUS tool. This is available within the resource pack. Step 2 considers unplanned weight loss over the last 3 to 6 months. This can be easily calculated using the chart within the resource pack. A score of 0 is given if weight loss is less than 5%, as this is considered to be normal variation. A score of 1 is allocated for 5 to 10% weight loss and a score of 2 for more than 10%. It is crucial to know whether weight loss is planned or not, and also to use the correct weights to calculate percentage lost. You should only include unplanned weight loss and always use the highest weight achieved in the last 3 to 6 months compared to what the resident weighs now. This is sometimes where mistakes are made. Step 3 considers acute illness combined with no nutritional intake for more than 5 days. This is unlikely to apply in care homes, although may be seen when someone is coming to the very end of their life. If this step applies, a score of 2 is assigned to this step. Step 4 involves adding the scores together from steps 1, 2 and 3. A total score of 0 means low risk of malnutrition, a score of 1 means medium risk of malnutrition, and a score of 2 or more means the resident is at high risk of malnutrition. For those using paper records, there is an example must recording chart within the resource pack, which can be used to record monthly must scores. Step 5 of the must tool suggests courses of action, including following local policy based on must score. Our resource pack includes a malnutrition care pathway for care home residents, which we recommend is used as your local policy. This suggests pathways for care planning specifically in care homes and has been created in line with best practice guidelines. We'll go over it later. We will also use some case studies shortly to practice calculating must scores.
First, let's talk about some other factors that might make it difficult to calculate a must score. If someone's weight changes drastically from month to month or week to week, you should question the accuracy and reweigh when possible. Be aware of whether they are holding on to something when being weighed, such as a wall or the bed, or perhaps the scales are faulty or have recently been recalibrated. If weights appear unusually high, perhaps different clothing or footwear are being worn, there are heavy items in pockets, or they have a catheter bag attached. Sometimes fluid retention can cause large changes in weight and can be difficult to estimate. In these situations, we would suggest referring to the must explanatory booklet found online. This suggests how to estimate a dry weight. So, for example, if someone has barely detectable edema, it suggests subtracting 2 kilograms from the weighed weight, or for more severe edema, you may subtract 10 kilograms to get a more accurate dry weight for them. For those who have had amputations, the must explanatory booklet also has a table which allows you to calculate pre-amputation weights depending on the site of amputation.
Obtaining an accurate height can also be difficult, particularly if you are unable to measure residents' height or if a resident has spinal curvature. It is worth checking with their GP in case they have a record of their height. If not, you could ask the resident or their family and friends if they know what their height is. Alternatively, the forearm, called the ulna, can be measured. The accuracy of this can vary quite a lot, but it can provide a rough estimate of height if all the other options have been exhausted. We will now quickly explain how to take an ulnar measurement. First, position the resident's left arm up against their chest with their hand on the opposite shoulder. Measure between the point of the elbow and the midpoint of the prominent bone of the wrist. Measure in centimetres and record in the resident's care plan. If you are able, please take a few minutes to practice taking an ulnar measurement on a colleague to ensure you are confident. Instructions for taking an ulnar measurement are also within the resource pack, as well as a table for converting the measurement into estimated height. Please note within the table there are different rows to choose from depending on whether your resident is male or female and their age. You can also calculate this using the Must online calculator.
If you're unable to weigh a resident, you will not be able to accurately calculate their BMI in step 1 or weight loss in step 2. In these cases, the Must tool suggests using subjective criteria. This means using other information to inform whether or not you think a resident is at risk of malnutrition. Although you can't assign an actual must score doing this, It can give clues and help to support your overall impression of malnutrition risk. We can use certain indicators to estimate BMI category, such as whether someone looks thin, an acceptable weight, or is overweight. This can be difficult if someone is covered up under layered clothing or bedding. You can also measure the mid-upper arm circumference, or Muak, and use the measurement to estimate BMI category. This measurement can also be useful to monitor someone over time when you are unable to weigh them, or if they're retaining fluid in their lower limbs or abdomen, but not in their arms. Instructions on how to measure Muak can be found in the resource pack. They are also within the Must tool, but we will go through it briefly here. Start by getting your resident to bend their left arm at a 90-degree angle and hold it against their body. Then measure between the bony protrusion on their shoulder and the point of their elbow. Find the midway point of this measurement. So for example, if the measurement is 30 centimetres, the midway point will be at 15 centimetres. Next, let the arm hang loose by their side. You then need to measure around the upper arm at the midpoint you have just identified. The tape measure should be snug but not tight. Make sure you take the measurement in centimetres, not inches. Record in the care plan. This is the table within the resource pack which shows that if Muak is less than 23.5 centimetres, you can estimate that BMI is likely to be under 20 and the person is likely to be underweight. If Muak is over 32 centimetres, BMI is likely to be over 30 and not therefore underweight.
If you have no weight history available, you will need to use subjective criteria to identify potential weight loss. You should ask the resident if possible, and if they can recall their usual or previous weight themselves, then you could use this. If not, family, friends or their GP may be able to tell you. If you are unable to find this out, you will need to look for visual signs such as obvious wasting and loose-fitting clothing, extra notches in a belt or loose jewellery. If previous mid-upper arm circumference measurements are available, this may help. As an example, a 10% decrease in mid-upper arm circumference is likely to equate to a 10% decrease in weight. Decreased intake and appetite or underlying disease or disability may also indicate that unplanned weight loss may have occurred. We'll go through this in more detail in one of our case studies.
Next, we encourage you to practice using the Must tool with some case studies. You might be surprised to see how different the examples are. This is Mabel. She is 82 years old and her carers are concerned that she may have unintentionally lost weight. She is eating small amounts but is not acutely unwell. Pause the slides and use the information provided on the slide to calculate her Must score using either the online Must calculator or the charts from the resource pack. The answers are on the next slide once you're done. You should have calculated a BMI of 20 with a score of 1 for step 1 and unplanned weight loss of 4 kilograms with a score of 1 for step 2. For step 3, you should have identified that Mabel was eating small amounts and not acutely unwell, so scored 0 for this step. This gives a total score of 2, so puts Mabel at high risk of malnutrition. All of the information was available in this example, so it should have been a straightforward calculation.
Next is Muriel, who is 95. She is bedbound and unable to be weighed, and there is no weight history available. This means that neither BMI nor percentage weight loss can be calculated. We know that she looks thin, has a decreased appetite, although is managing small amounts, and her jewellery is loose. She is not acutely unwell. We have a mid-upper arm circumference measurement for her of 22 centimetres, and we know it was previously 26 centimetres. How would you determine her risk of malnutrition? You could use the subjective criteria page within the resource pack, which corresponds with the steps 1, 2 and 3 of the Must tool. However, you cannot assign an actual Must score using this, but it gives clues and helps to support your overall impression of malnutrition risk. You could also use the mid-upper arm circumference to estimate BMI category using the information in the resource pack. Pause the slides and use this information to decide whether or not you think Muriel is at risk of malnutrition. Continue playing the slides when you're done. So you weren't able to calculate a must score for Muriel as the information was not available. You may have estimated that her BMI was less than 20 using her mid-upper arm circumference, and therefore she is likely to be underweight. The visual signs and reduction in mid-upper arm circumference indicate that she has probably lost weight, and we know that if she is still eating small amounts and not acutely unwell, then we wouldn't have assigned a score for acute disease effect. From this, we can say that she is likely to be at either medium or high risk of malnutrition.
This is Joan. She is 76 years old and recently been discharged from a long hospital stay, having lost a lot of weight. Calculate her must score with the information provided. The answers are on the next slide, so pause and continue when you're done. You should have calculated a score of 0 for step 1, as Meryl has a BMI of 35, so falls in the obese category. For step 2, you may have been in doubt over which weight to use. As previously mentioned, this should always be the highest weight available within the last 3 to 6 month period, so in this case, the 5-month weight, so total weight loss of 10 kilograms. You may assume that if someone is obese, then any weight loss is intentional or not concerning. However, when weight is lost unintentionally, it is very likely that muscle mass is lost, which leads to significantly increased health risks. In this case, we know that the weight loss was unplanned, so we give a score of 2 for step 2. Meryl is not acutely unwell, so scores a 0 for step 3, and an overall score of 2, putting her at high risk of malnutrition.
A common question we get asked by care homes is about whether we should be encouraging obese residents who have unintentionally lost weight to regain that weight. This is a good question and a really important point. When considering a course of action for managing malnutrition in obese residents, you should first consider how well they are eating. If their appetite has returned to normal, they should be encouraged to follow a healthy, balanced diet with sufficient protein in order to regain strength, but not necessarily regain weight. However, if their appetite and intake remain poor, you should consider following the malnutrition care pathway in the resource pack with the aim of maintaining weight whilst they remain unwell. After they have recovered, regained their strength, and their appetite is back, it will depend on whether their excess weight is affecting their health. For example, difficulty in controlling diabetes or affecting mobility. In general, if excess weight is not causing adverse effects to their health, we would not necessarily encourage planned weight loss. However, if it is affecting their health, you might want to encourage a gradual weight loss to help with this.
In this section, we discussed nutritional care planning and treating malnutrition risk for care home residents. So, what should be included in care plans, how often they are reviewed, and how care plans might be communicated to the relevant staff so that actions are carried out. Section 3 of the pack gives a clear pathway for managing malnutrition risk based on must score and using a food-first approach. It is a step-by-step process that will enable you to create patient-centred care plans detailing what the aim is, exactly what intervention is needed, and what is or isn't working in order to make progress and to manage malnutrition risk. The pathway links you to various useful checklists, templates, and supporting information within the resource pack, which we will come on to mention in a minute. As previously mentioned, we are encouraging all care homes within Cornwall to use this care pathway as their step 5 within must. The pathway splits into 2 sides depending on must score. The pathway highlighted in blue is the pathway for a must score of 0, so low risk of malnutrition. We suggest that the resident should have a nutritional care plan that is regularly reviewed and updated with changes, and they should continue to be must screened monthly. There is an example of a nutritional care plan within the resource pack which goes through all the information you should be recording for your residents. Make sure you also record a nutritional aim for your resident. We will talk about this a bit more in a few minutes' time. If the resident has a pressure ulcer or wound that is not healing, food and fluid intake should be assessed. If there are concerns about food and fluid intake, it may be beneficial to follow the pathway for a must score of 1 or more, with an emphasis on higher protein options, and we will cover this next. If there are no concerns about their intake, you should continue to follow the must zero pathway and screen monthly.
So, for those with a must score of 1 or more who are at medium or high risk of malnutrition, the must 1 or more pathway should be followed and is highlighted in blue. Again, we suggest that the resident should have a nutritional care plan that is regularly reviewed and updated with changes. You also need to make sure you record all the assessments and outcomes gathered as part of this must 1 or more pathway within the nutritional care plan, and the pack has an example of how you may do this. The first step of the pathway is assessing underlying causes of malnutrition, which we covered earlier in the video. Next, you will need to set a nutritional aim for your resident. This might be to prevent further weight loss, to maintain weight, or to increase weight. If someone is end of life, the aim might simply be to maintain quality of life. Sometimes we are asked by care homes about residents who have always been a low weight for their whole life and whether they should be encouraging them to put on weight. We would advise talking with your resident about their weight and the potential benefits of a small amount of weight gain to see what they would like to do. If they are currently eating well and their weight is stable and they would prefer to maintain their current weight, then they should be supported to do this. Next, we would encourage you to assess food and fluid intake for 4 to 7 days. Make sure you include details such as amount of food eaten. There is a food and fluid checklist in the resource pack which can help you to assess your residents' intake. We would also encourage that you observe 2 meal times, and there is a checklist in the resource pack that can identify problems that affect nutritional intake. After you have done all the assessments mentioned, we would then encourage you to take a food-first approach to improving your residents' diet, which we will go through in a minute. For all your residents at risk of malnutrition, we would encourage you to consider offering them an over-the-counter vitamin and mineral supplement. This might be, for example, if they are eating particularly small amounts of food or a small variety. This would come under self-care, but should be agreed by the resident's GP. We would encourage you to weigh residents weekly when their must is 2 or more, or when there is clinical concern.
Food First is the first-line treatment for those at risk of malnutrition. It includes principles such as eating little and often, food fortification, and providing nourishing drinks. We often see that people with smaller appetites are overfaced by big meals, so offering smaller meals alongside regular nourishing snacks and drinks is likely to result in a higher intake. Fortifying those meals means increasing the nutritional content without adding volume, by adding items such as cream, cheese or butter, for example. In terms of drinks, low-calorie or low-sugar drinks should be minimised, and higher-calorie drinks or homemade fortified drinks should be encouraged. Food First treatment can be implemented without the need for a dietitian, and can often resolve the malnutrition risk without a dietitian or a GP needing to be involved. Staff may still wish to advise the GP of any weight loss, and the GP will certainly find it useful to know that action is being taken to treat the malnutrition risk. In some cases, a dietitian referral may be needed, but we'll talk about that later. In Cornwall, we have adopted a 1-2-3 approach to Food First. This refers to offering those at risk of malnutrition 1 pint of fortified milk per day, at least 2 nourishing snacks, and 3 2-course fortified meals a day.
Fortified milk is made by adding 4 heaped tablespoons of skimmed milk powder to normal full-fat or blue-top milk. The full recipe and ideas on how to use it can be found in the resource pack, but put simply, it can be used in place of normal milk in many drinks, main meals, puddings and baking. Using fortified milk can be a very simple and effective way of boosting nutritional intake without adding extra volume. We've found that since giving this training around Cornwall, care homes have found fortified milk one of the easiest things to start using with their residents. On screen are some examples of where fortified milk can be used in breakfast or main meals. And here are some ideas of where you can use fortified milk in puddings and drinks.
So next, number 2. This refers to offering a minimum of 2 nourishing snacks per day. Snacks should total at least 200 calories altogether. You should offer a wide variety of different snacks every day to keep residents interested in snacking. If giving biscuits, opt for high calorie ones and try serving fruit with custard or cream. There are plenty of everyday snack ideas in the resource pack. Snacks should be given little and often and away from meal times so they don't affect intake at the next meal. Ideally, they should be offered mid-morning, mid-afternoon and before bed. Bedtime can be a really useful time to offer snacks as they won't affect appetite for the next meal. Discuss with your residents whether there is anything in particular they'd like to have as a snack before bed. We recommend that at least one of the snacks is a high-calorie fortified snack, which we will discuss next. Our top recommended high-calorie fortified snack is a fortified yoghurt. So, a normal thick and creamy yoghurt with 1 heaped tablespoon of skim milk powder and 1 tablespoon of double cream, which almost doubles the calories and protein content. This could be used as a snack or as part of a pudding or breakfast. Within the resource pack are recipes for a fortified lemon cream and a fortified chocolate caramel cream. These are high in calories but lower in protein, and we would suggest only offering these once a day.
So finally, the number 3 of the 1-2-3 approach means 3 two-course fortified meals. We've already mentioned that food fortification means adding certain ordinary food items that are high in calories or protein to other foods to increase the nutritional content without increasing the volume. This is essential when those at risk of malnutrition are eating much smaller portions and also helps make the most of eating little and often. Homes quite often tell us that they are already fortifying food as they add some butter to their mashed potato. However, what we mean is adding more than just butter to mashed potato. For example, adding a bit of extra skimmed milk powder and cheese as well. We might also suggest adding to the rest of the meal, for example adding butter or sauces to vegetables, using fortified milk in milk puddings and custard, and adding cream or ice cream to fruit and other puddings. The important thing is to add more for those who really need it, so those at risk of malnutrition, and not necessarily for everyone. It is really important to add these extras to meals and puddings as much as possible. This is a simple chart giving examples of foods that you can use to fortify with. On the left are those high in calories and protein, such as skimmed milk powder, cheddar cheese, nut butters, chopped or ground nuts, and thick and creamy yoghurt. On the right are those high in just calories, but not so high in protein. It is important to remember to regularly fortify with foods containing protein and not just foods that will only add extra fat and calories, such as butter and cream.
You may have residents in your home who require texture-modified diets. Foods and drinks have been classified by the International Dysphagia Diet Standardization Initiative, or IDSI, according to their texture, and the diagram on screen represents the different levels of food and fluid that may be recommended for your residents. The consumer handouts under the resources section on the IDSI website give lots of ideas for foods of every texture. Make sure you know which IDSI level your resident needs for food and drinks, and ensure whatever food and drinks you give are appropriate to that individual. Remember, if you are fortifying meals, snacks or drinks, that this can change the end consistency. Care home staff should always follow the IDSI guidance for testing textures to ensure that all food and drink is a suitable consistency for their residents. Testing foods can be quite simple and involves using a fork or spoon, and information on doing this can be found on the IDSI website.
For some residents, the use of homemade fortified drinks may be needed in addition to the 1-2-3 approach. Recipes for these are provided in the resource pack, and the most nutritionally complete ones with the most calories and proteins are a fortified milkshake and a fortified hot chocolate. Both are made with fortified milk and double cream and use a milkshake or hot chocolate powder that is fortified with vitamins and minerals, which is really important. The recipes have been formulated to be nutritionally similar to prescribed supplements and are concentrated in both energy, protein and vitamins and minerals. It is important to follow the recipes without adding to the recipe or changing it, as this can reduce the energy and protein concentration of the drink. For those residents who are not able to have milky drinks, we have included a fortified fruit juice. We also have recipes for fortified soups and have recently added a dairy-free recipe to our resources. We recommend giving 1 to 2 of the homemade fortified drinks per day where residents have a must score of 2 or more, or if weight loss or poor intake continue despite other dietary changes being tried. Most of the recipes make a drink about 200 to 250 ml in volume. If a resident finds this too much, the drinks can be split into smaller shot-style portions, which might be more manageable. If you have a few residents who are being offered these drinks, you could make the recipes up in bulk at the start of the day and keep these in a jug in the fridge, ready for the drinks rounds or when the resident may want it. A couple of flavours could even be made each day to give more choice to residents. Remember to discard any that has not been used after 24 hours. We always encourage homes to try offering homemade fortified drinks first rather than requesting prescribed supplements, as prescribed supplements may not be necessary much of the time.
Oral nutritional supplements can play an important role in improving nutritional intake in some circumstances. However, they should only be prescribed when there is a risk of malnutrition and nutritional needs cannot be met with food alone, and ideally the resident should have had a full assessment by a dietitian. In care homes, adequate quantities of good quality food and drink and homemade fortified drinks should be sufficient most of the time without the need for prescribed oral nutritional supplements. Oral nutritional supplements have strict criteria to meet in order to be prescribed. They are not to be used if a resident is not enjoying the food and drink offered by the home. The home has a responsibility to offer alternative choices to make sure that nutrition and hydration needs are met. They are not intended to be used as meal replacements, and they should also not just be given if requested by a family member.
We just want to reiterate at this point that this high-calorie, high-protein approach is just for those residents at risk of malnutrition and is not a blanket approach for everybody within the care home. This is sometimes misunderstood. Next, we are going to take a look at a hypothetical day's intake for a resident who is not eating well and is at risk of malnutrition, and how we might go about improving it using the 1-2-3 approach. So, the meals for the day are a medium bowl of porridge for breakfast, a small portion of cottage pie and vegetables for lunch, and a light evening meal of a ham sandwich and some peaches and syrup for pudding. All of these meals are under 300 calories and provide less than 15 grams of protein each. Moving on to snacks, they are having a biscuit mid-morning and another in the evening. For drinks, they are managing 4 cups of tea and a cup of coffee. We can see that this person's snacks are quite minimal, and the drinks provide a reasonable amount of fluid, but not many other calories or protein, even though they have been made with whole milk. So the total for this person's intake is less than 1,000 calories and only about 36 grams of protein. This is unlikely to be enough to sustain an adult's weight, so it is not surprising that this resident is losing weight and is at risk of malnutrition.
So, let's think of how we might use the 1-2-3 approach to boost the nutritional content of this person's diet in order to manage their malnutrition risk. If we used some of the fortified milk in the porridge and added 10 grams of ground almonds, for example, This would add over 100 calories and 8.5 grams of protein and wouldn't make the porridge any sweeter or increase the volume. You could of course add things like sugar, jam and syrups if they were tolerated to add even more calories. If they could manage it, you could encourage a second course such as toast with butter and jam. Next is lunch. By adding 30 grams of cheese and 10 grams of butter to the cottage pie and vegetables, we add about 200 calories and almost 8 grams of protein without making the portion any bigger. You could of course encourage a pudding as well if tolerated. For the evening meal then, if we added half a tablespoon of mayonnaise to the ham sandwich and a tablespoon of cream to the tin peaches, that would add another 147 calories and 4 grams of protein. With the snacks, we could swap the morning biscuit to half a scone with butter and jam and swap the evening biscuit for a fortified yoghurt. This gives an additional 358 calories and 10 grams of protein, adding a really good amount to the overall total. Alternatively, you could change to high-calorie biscuits if preferred, or spread plain ones with butter, Nutella, nut butter, or add cheese. You could encourage a third snack if there was an appropriate time in the day for this. Finally, the drinks. Using fortified milk in the cups of tea and using it to make a milky coffee would significantly increase the calories and protein from these drinks. This adds almost 200 calories and 14 grams of extra protein without increasing the volume. This example day shows how simple and effective it can be using the 1-2-3 approach before considering adding additional courses or nourishing and homemade fortified drinks. We can see that the total calorie and protein intake for this day has almost doubled without adding any significant extra volume. It is important to remember that there are lots of different ways to fortify a resident's diet, and where possible, it is important to ask the resident what they prefer their food to be fortified with. Drinks can be a really useful way of increasing calories and protein intake, especially when someone is eating very poorly.
So now we have discussed what dietary changes can be tried, it is really important to make sure that any changes are clearly documented and most importantly communicated to the right people. It is important to regularly communicate with your residents where possible about their likes and dislikes and how they are finding the dietary changes that have been made. If they do not like all the changes made, it is important to find alternatives that are more acceptable to them. For example, if a resident is struggling to finish a pint of fortified milk a day, you may want to try offering more high-calorie snacks to compensate for this. Or maybe the resident finds meals fortified with butter and cheese too rich, so you may decide to focus on more nourishing drinks and snacks instead. Regular communication with other care home staff is important so that you are aware of the nutritional needs of each of your residents. Make sure that you have access to all the relevant information from the residents' nutritional care plans, such as any special dietary requirements and food-first approaches needed. Communication of this information can be via verbal handover or a whiteboard or a folder in the kitchen. Choose whatever system works best in your home, but ensure the information is detailed and updated regularly so it is clear what needs to be provided to the residents. Many residents may require additional snacks or nourishing drinks once catering staff have left for the day. Ensure that these are available as needed and that other care home staff know how to access them and which residents they are for.
Once you have met the resident's aim, so for example they have reached their goal weight and appetite has returned to normal, any changes made should be gradually reduced whilst weight continues to be closely monitored. So you might reduce the food fortification and high-calorie snacks and find a well-balanced diet that helps the resident maintain their improved nutritional status. And as always, make sure the care plan is updated accordingly. If you find that the dietary changes are having a limited impact and the aim is still to gain weight or reduce malnutrition risk, care homes should consider requesting a dietetic referral through the GP. Dietetic referral should be requested particularly if there is a must score of 2 or more and no improvement, or if a weight or if weight loss is ongoing over a 2-month period and if all of the dietary interventions have been tried. This might apply to those who have a very restricted diet or residents who have pressure sores or wounds that are not healing despite additional higher protein options being tried. There may be times when referring to a dietitian may not be appropriate, for example, if a resident is coming to the end of their life. Consider what you are aiming for and whether any benefit is expected from nutritional support. If you think making dietary changes is likely to be more detrimental or distressing for a resident, it's unlikely that referral to a dietitian will be useful. However, this isn't always easy to determine, and you should discuss with the resident's GP.
Within the resource pack, there is additional information on dementia, diabetes, texture-modified diets, oral health, end of life, hydration and constipation. There will also be an additional training video containing this information. So that brings us to the end of the training. We hope you have enjoyed this training and gained knowledge that will help you to feel confident in managing malnutrition in your care home. Please complete the SurveyMonkey. Your manager can give you details. Please advise your manager once you have done this and we will issue a certificate of completion. Please do contact us if you need extra support or would like us to provide any further training in the future. Thank you for watching.